Ladies and gentlemen, it's an honor to be here. It's my first time in Hong Kong, and it's been fantastic so far, very welcoming. And it's an honor to address the question whether contrast-induced AKI or contrast-associated AKI is still a problem in clinical practice. These are my disclosures, but they have not affected what I'm going to say in the next 20 minutes. So we all know about contrast-induced or contrast-associated acute kidney injury. There's a lot in the literature. If you compare different studies, you'll find variances in the incidence reported in the various studies. And you'll also see that different investigators use different criteria, which may have affected the incidence and outcome. And most work was actually done in cardiac patients undergoing coronary angiography or percutaneous coronary interventions. Less was done in patients undergoing elective radiological procedures with contrast. As I've already said, studies have used different criteria, mainly because there is no consensus on the exact definition of acute kidney injury, but these are the most commonly used definitions. Studies or investigations have used creatinine rise by either 0.5 or 0.3 milligrams in 48 hours, and others have looked at a creatinine rise by more than 25%. So a lot of variation, and also still a lot of confusion. The fact that contrast may be harmful to kidneys is logical, makes sense, because contrast material is quite an unusual substance. There's a lot of variation, as shown here. We have high, low, and isoosmolar substances, and they vary in their osmolarity. And as you can see, some of them are, in some, the osmolarity is significantly higher than the osmolarity of plasma. They also vary in their viscosity, as shown on the right, and they contain iodine. Just for your information, these viscosity numbers don't really mean much, but essentially what they tell us is how much more viscous a substance is compared to water. And just as comparators, I've listed oil and maple syrup there. So the bottom line is the higher the number, the thicker the substance. So they are different from plasma, and they are thicker, contain substances which are not normal to plasma. And therefore, it's not surprising that these substances can have nephrotoxic potential. In animals, studies have looked at the mechanisms how contrast may be nephrotoxic, and they found various pathways and processes. So as a result of the unusual nature of the substance, they can stimulate the release of adenosine and endothelin, which then has vasoconstrictive properties. Clearly, the increased viscosity will lead to an increased viscosity in the plasma, and this will have effects and an impact on the microcirculation. And as shown here by this glomerulus, or by the nephron here, the microcirculation is essential to renal function. And as a result of the unusual composition, they also have direct tubular toxic effects and induce the generation of oxygen-free radicals, which again can lead to some inflammatory processes. So there are numerous ways how contrast can be nephrotoxic. And I've already said we have studies showing that patients who had contrast subsequently had a rise in creatinine, which implies that they developed acute kidney injury. Here is one of these studies, and I've picked it really to highlight one of the problems of many of the studies. So this is a study which is a sub-study of a large cardiology study where they compare two different anticoagulants. And in this sub-study, they looked at the incidence and the outcome of patients who had developed acute kidney injury. Using a creatinine rise of more than 0.3 milligrams per deciliter, which is consistent with the KDIGO classification, they found that 20% of patients had a creatinine rise consistent with a diagnosis of acute kidney injury, and they were labeled as having contrast-induced acute kidney injury. So in this study, it was very common. And then they went on and wanted to explore the outcome of these patients with particular attention to mortality and major adverse events within the subsequent 36 months, so 3-year outcome data. And I'll show you some figures here. Essentially, in all 4 figures now, the patients with acute kidney injury are displayed in red, and patients without contrast-induced acute kidney injury in blue. And as you can see here, it's patients with acute kidney injury immediately after this emergency procedure had a higher rate of all adverse events. They had a significantly higher rate of adverse cardiac events in the subsequent 36 months. They had a higher risk of major bleeding and a higher risk of dying. Not only was acute kidney injury common, it also had significant long-term effects. And so the authors of this paper concluded that contrast-induced acute kidney injury was serious and associated with harmful short and long-term problems following a PCI, following a percutaneous coronary intervention, following an acute MI. But when you read the paper, it becomes clear that there are quite a lot of limitations. And I show them here because this is the problem with a lot of these studies. So in this study, the patients included were obviously patients who had an acute MI undergoing an emergency procedure. And when you go through the patient characteristics, it's clear that they all had many other risk factors for acute kidney injury. A large proportion of patients was hemodynamically unstable. A large proportion had some other complications, including bleeding. This was, after all, an anticoagulation study. Some of them had concomitant nephrotoxic drugs, and there was also an element of cholesterol embolization. So a lot of overlay and confounding in this study, but in several other studies. And so the authors of this paper here try to unpick this a little bit and unravel this and see whether it was contrast or whether there were maybe other reasons. So in this study, they looked at 380 critically ill patients admitted to 2 intensive care units. And they looked at the incidence of acute kidney injury in patients who had had a radiological procedure with contrast compared to patients who had had a similar radiological investigation without contrast. And they were considered to be similarly sick. All of them were in the intensive care unit, all of them requiring investigations, radiological investigations to make a diagnosis and investigate their underlying disease. And if you compare the 2 groups, as was done here in the figure, then patients who had had a radiological investigation with contrast, displayed in the darker bars, indeed had a little bit more acute kidney injury compared to those who had a similar investigation without contrast. But the differences were trivial at 48, 72, and 96 hours. And statistically, they were not significant. And then they went further and said, well, these are patients who are very sick. They're in the intensive care unit. Critical illness as per se is a risk factor for acute kidney injury. Let us look at other risk factors in both patient groups. And they performed a multivariable analysis controlling for the usual risk factors for acute kidney injury. And as you can see here, it was severity of illness as defined by the SOFA score, and the number of associated nephrotoxic drugs, which were independently associated with the development of acute kidney injury. And when you controlled for them, the administration of contrast was no longer independently associated with acute kidney injury. It was no longer an independent risk factor. And so the authors of this paper felt that the specific contribution from contrast in ICU patients requiring an investigation with contrast was minimal, and that other factors had a much greater impact, in particular severity of illness and the global nephrotoxic burden. In the last 2 months, as you may have seen if you've followed intensive care, there have been more papers questioning the existence of contrast-induced acute kidney injury or contrast-associated acute kidney injury. The one was done by Professor Kashani from the Mayo Clinic. And he and his colleagues reviewed a large database with patient data of 12 years. And again, they wanted to see whether in this very sick group of patients with multiple risk factors for acute kidney injury, whether in this group contrast was independently associated with acute kidney injury, whether it was in the risk factor for renal replacement therapy and for mortality. They identified more than 4,000 patients who had had intravenous contrast, and they identified 2,526 similar patients who had not had contrast during their stay in the intensive care unit. And then they performed a propensity score adjusted analysis, controlling and matching various patients. And to cut it short, as you may have seen from the paper, which is online, it's not hasn't been published in paper format yet, they found that there was actually no difference in the risk of acute kidney injury or need for renal replacement therapy in those who had reasonable renal function to start with. So in those who had an estimated GFR of more than 45 mL per minute prior to the intensive care unit, had enough renal resource and enough renal reserve to cope with the extra burden of contrast. In patients who had less renal function, with an estimated GFR of less than 45 mL per minute prior to coming to the intensive care unit, they had a slightly higher risk of needing renal replacement therapy, but no other increased risk following contrast. And again, the authors questioned whether the existence of contrast-induced AKI in patients with reasonable renal function. In the same month, a similar paper, or a paper addressing the same question, was published, again in the same journal, and it's available online. Professor Ehrman and his colleagues, again, tried to explore the question, does contrast per se cause acute kidney injury or lead to acute kidney injury during critical illness? And they performed a meta-analysis analyzing the data of existing studies. And they were particularly interested in studies where the investigators had included baseline AKI risk information and where they had done appropriate patient matching. And using these criteria as a prerequisite, they found 3 papers where they felt enough control had been done to control for baseline risk factors. And when they analyzed these 3 studies, again, there was no evidence that the administration of contrast had increased the incidence of acute kidney injury. So we've moved away from being very worried about contrast to latest studies suggesting that maybe it's not quite as bad as we think. And maybe in the critically ill patient population, where there are lots of risk factors, contrast administration plays a minor role. Some people have suggested that we should, in light of these findings, maybe change the term and no longer talk about induced acute kidney injury or contrast-induced nephropathy, and maybe we need to find a different term like contrast-associated or post-contrast AKI. There's still some debate. This has not been decided yet. But certainly these recent studies have led to quite a lot of discussion amongst experts in the field. Nevertheless, it is a substance which has potential to be nephrotoxic. And for certain patient groups, it does increase the risk of AKI. If you look at the risk factors, as listed here, there will be some patient-related factors, and there will be some factors related to the procedure. If you then think about what can you do to influence this and minimize the risk of nephrotoxicity, you actually have limited options. Because amongst the patient factors, there's very little you can do apart from preventing volume depletion and maybe preventing hypotension before contrast is administered. But most other risk factors are not modifiable. With regard to the procedure itself, if you've decided a procedure is required, then all you can really do is minimize the burden and maybe persuade your radiologist to select a contrast with a low osmolarity. But the choices are limited if you want to modify risk factors. You could then say, well, is there anything we can do to modify the processes, these pathophysiological processes, how contrast potentially could act? And I showed you earlier on what contrast can, or the effect of contrast on the nephron in animals. And if you say, well, let's see what we can do to alter and influence these processes, well, that's the reason why people have looked at the use of fluids, N-acetylcysteine, statins, anti-inflammatories, or preemptive renal replacement therapy, all with the intention to modulate and manipulate the pathways and the nephrotoxic processes of contrast. Fluid and NAC have been the most studied drugs or substances. And the reason for fluid is obviously clear. The reason is that any effect of contrast, especially if you use a substance with a high osmolality and high viscosity, it will be reduced if you volume resuscitate the patient and dilute the plasma a little bit. And that's a theory behind giving fluid. The fluid may also have some positive effects on the manipulating the vascular tone and preventing any endocrine hormonal alterations in the kidneys. With regards to substances, to the type of fluid, people have discussed and studied at length the benefit of saline versus bicarbonate. The second substance is obviously NAC, and NAC has been studied in numerous studies with very conflicting results. And it may be that these results are conflicting because of the nature of N-acetylcysteine. If you really look at it and study the pharmacodynamics of NAC, it's a substance which has a very low bioavailability if used as an oral format, and if you use it as an IV administration, it binds rapidly to other tissues and may actually not get to the kidney, or not only small proportions may get to the kidney where its mode of action is. And this may explain some of the conflicting results in various studies. So in the last few slides, I just want to show you briefly what is currently recommended. The KDIGO guideline from 2012 reviewed the literature up to 2010, and up to 2010, the data suggested that there was enough evidence to recommend fluids to prevent contrast-induced kidney or nephrotoxicity. There was no clear signal whether one type was better than the other. And with regards to substances, the KDIGO expert committee felt there was not enough evidence to suggest that any of these potential pharmacological measures had a role. A year later, the National Institute for Health and Clinical Excellence in the UK looked at all the data again, data up to 2012, and they concluded that there was only a role for fluids. Again, they felt there was not enough evidence to suggest one fluid over another. They also felt that the nephrotoxic burden should be reduced and recommended to discontinue any other nephrotoxic drugs. And they felt there was not enough room and not enough data to recommend NAC. And then finally, just a few months ago, the French Society of Anesthesia and Resuscitation looked at measures to prevent acute kidney injury. And with regards to the acute kidney injury after contrast, they concurred with the previous guidelines, after having reviewed more recent literature, and again saying there's only evidence for fluid, there's no evidence for NAC or any other pharmacological measures. So it appears up till now, up till 2 months ago, it appeared that IV fluids was the only mainstay of therapy. And then obviously, as you may know, this paper was published in The Lancet, which has led to even more controversy. In this paper, patients undergoing elective radiological procedures with contrast were randomized to IV fluid versus no prophylaxis. And the investigators focused on patients who had reasonable renal function. They excluded patients with chronic kidney disease, stage 4 or 5. So patients with an estimated GFR of less than 30 were excluded. After having enrolled 660 patients, they found no difference in the incidence of acute kidney injury, no difference in the need for renal replacement therapy, and no difference in mortality between groups, the two groups, the group which had received IV fluids versus those who had not received anything. And in fact, they pointed out that those who had received fluids had slightly more complications related to fluids. Now, this caused a lot of controversy, and they were asked to do numerous sub-analyses looking at patients who had IV versus intra-arterial contrast, diabetics versus non-diabetics, patients with GFR less than 45 versus those with a higher GFR. And to cut it short, in all of these sub-analyses, there was no difference between those who had fluids and patients who hadn't. And in my practice, this paper has already led to quite a lot of discussion where people have come to me and say, should we just not give anything? Before we take this paper and translate it into critical care practice, I think it's important to remember these were elective procedures and these were not critically ill patients. It may be that IV fluids have no role, I don't know, but these were a different patient population from patients we see in the intensive care unit. So I think at this point, there is clearly a lot of uncertainty, but from what we've got at the moment, it appears that contrast administration during critical illness in patients who have so many risk factors only represents a small additional nephrotoxic burden. Radiocontrast procedures should not be avoided if they are necessary, but clearly if they can be avoided and be replaced without contrast, that would be better. And during critical illness, hypovolemia represents a risk factor, and therefore hypovolemia needs to be corrected or prevented or avoided. And if this means IV fluids, I would say at this point patients should still have some IV fluids, and I don't think the Lancet paper is enough to change practice in the intensive care unit. With regards to other drugs, it appears there is no role at this point, and that's confirmed by numerous guidelines from various societies. Thank you.